thoracic meningoceles, the lateral and anterior meningoceles. One on your left shows the lateral, almost looks like a myelogram, conventional myelogram we used to do to depict thoracic meningoceles, the lateral and anterior meningoceles. One on your left shows the lateral, almost looks like a aortic knob, but it's a myelogram. One in the middle, anterior meningocele, multiple anterior meningoceles, one on your right side. MRI, lateral thoracic meningocele, one on your left side, and shows on cross-sectional and coronal sections also. Lateral meningoceles, a word about it, due to weakened dysplastic meninges that protrude through enlarged endovertebral foramina. They are also sometimes called pulsion diverticular. Thoracic most common, usually on right side. Lumbosacral, cervical also can occur, but they are less common. What does CT show? Dumbbell-shaped CSF contained lesions protruding through enlarged neural foramina and with adjacent thinned pedicle and of course scalloped vertebral body even in the lateral margin. MR, CSF signal and all sequences. That's how you identify these meningoceles. Reference AJR 133, meningocele in NF1, MR pictures. You could see lateral meningoceles both in sagittal views, thoracic and cervical. Now, what are the skeletal manifestations, peripheral skeletal manifestations? So far we have mentioned about the skull and axial skeleton. Now we go to the peripheral. Hypertrophy of a limb bone or atrophy, erosions, intraosseous cystic lesions in the marrow, and medullary streaking, columnar streaking. Example, right shoulder, neurofibromatosis. See the intraosseous neurofibromatosis. This is proved by surgery, not radiologically. If there is a picture of generalized neurofibromatosis, say cutaneous neurofibroma, and you clinically you diagnose NF1, you take symptomatically an X-ray shoulder or other, you see intramedullary cystic lesions, think of neurofibromatosis. Lytic lesions in the humerus, and of course skin lesions are also seen. They are shown by arrows. Forearm, on your left side, look at the atrophy of the ulna, erosion, and atrophy of the distal end of the radius with diffuse soft tissue swelling due to plexiform neurofibroma. Foot, look like the animal's foot. Look at the hypertrophy and sometimes atrophy of the 4th and 5th metatarsal digits. Foot again, neurofibromatosis. Differential diagnosis, when I show it to the residents or junior radiologists as a quiz, everybody says it is lipomacrodystrophy, but differential diagnosis should be made between these two. For example, what is the differential diagnosis in general? 1, neurofibromatosis. 2, the so-called Milroy's disease, that is primary lymphatic aplasia, rectasia. Proteus syndrome is part of it. Klippel-Tinani-Weber syndrome. Hemangioma, histolocalized hemangioma, can produce hypertrophy or erosions. But there, the classical feature is clippoliths. Macrodystrophia, lipomatosis. There should be a lot of fat. Again, the lateral view of the foot and ankle. NF1, note hypertrophy of the soft tissues. Of course, there is some fat tissue degeneration. Erosion of calcaneum, sclerosis, scallop and sclerosis, indicating there is a chronic feature, not the acute feature. And disruption of tarsal joints also. As I described earlier, cystic and streaky lesion in the femur, lower end of the femur, and of course tibia. Given this alone, you may not be able to diagnose. Sometimes chondromatous lesions, Olier's disease, you may get similar types of lucencies, but given a picture, clinical picture of neurofibromatosis and taking these into consideration, you should think of neurofibromatosis. And in the ribs, cone view of the ribs, look at the elongated, thinned out ribs. And what about the differential diagnosis in thin ribs? Collagen disorders like scleroderma, neurofibromatosis, progeria, osteoporosis, you can get thinned out ribs but not elongated or distorted. hyperparathyroidism due to subperiosteal or subcortical resorption of bone, idiopathic, we don't know why sometimes. Sometimes in scoliosis, the contralateral ribs are also thinned out. That's why idiopathic. Neuromuscular disorders like Wedding-Hoffmann and other muscular disorders also, you may get thin ribs. Again, and one on your left shows diffuse proliferation of the skin called elephantiasis neuromatosa. Clinically, it looks like elephantiasis. And on your right, diffuse plexiform fibromatosis. Again, localized neurofibroma on the right thigh and hip area, soft tissue swelling, deformities of the head and neck, and hypoplastic obturator ring, and streaky lines along the neck of the femur. On your left tibia, the lower limb, calcifications in neurofibromatosis. It's rare, but can occur. Of course, brain we have already described, but in the soft tissues, in the peripheral skeleton also, you may see the calcifications. And of course, multiple intraosseous defects. Rarely, it was described by in the Jacobson's book, and we have seen, rarely subperiosteal hemorrhage also may be seen with calcification. Given this, all you say is subperiosteal hemorrhage. Supposing it's a child, it could be scurvy. Youth, it could be hematoma due to in hemophilia. Massive subperiosteal hemorrhage in neurofibromatosis, described by one of our friends, Agmai. In AJR 122, page 439. Supraclavicular mass, twisted clavicle, and we have earlier noted twisted ribs. Here it is a twisted clavicle due to soft tissue neurofibroma, plexiform type. One on your right side, again you see soft tissue swelling of leg and ankle. A slight hypertrophy of the lower ends of the tibia and fibula. Hands. Again, a spectrum, intraosseous defects, deformities of the phalanges, elongated second metacarpal, short metacarpal and phalanges in the thumb. These are all the spectrum of dysplastic changes. Again, one on your left is neurofibromatosis, one on your right, macrodystrophia lipomatosa. See the difference. Here it is diffuse, it is only one digit all the way. And you get pseudoarthrosis because of the neurofibroma. Dysplasia again is the pathogenesis of fracture and pseudoarthrosis. Sharp edges. In traumatic pseudoarthrosis, usually you don't get sharp edges. Again, examples of pseudoarthrosis. And what is the differential diagnosis? In a child or an infant, if he or he presents with a deformed limb, I first think of congenital. And then, congenital what? Maybe if you dissect, there may be some neurofibroma element. Post-traumatic, we already mentioned, fibrous dysplasia, osteogenesis imperfecta, post-radiation, and of course, neurofibromatosis. Very common. Evolution of pseudoarthrosis in a child, look at from left to right in an F1. 10% of neurofibromatosis patients develop the fracture first and then pseudoarthrosis, particularly in the distal half of the tibia. 50% of congenital pseudoarthrosis, as I mentioned, most of them are due to neurofibromatosis. Again, involving the knee, look at the deformity, look at the exaggerated intercondylar notch in the femur, and one on your right, cystic changes in the left tibia. And what are the associated malformations in an F1? Euchromocytomas, interstitial lung disease, something like a honeycombing due to fibrosing alveolitis, renal artery stenosis, and sometimes it is due to compression of the renal artery producing hypertension by neurofibroma. Fibrous dysplasia, associated feature. Remember the original description of elephant man. Medullary thyroid carcinoma, other tumors of endocrinal glands, for example, MEA, multiple endocrinal adenomatous, 2B and 3 syndrome. Rickets and osteomalacia may be associated. atlantoaxial dislocation, cardiovascular, congenital heart disease, particularly aortic stenosis and coarctation of the aorta. Look at the lateral use of the leg, neurofibromatosis with rickets and deformity, and a looser zone is noted. Again, intercostal neurofibroma, own view of the chest, soft tissue mass with erosion of the rib and widening of the intercostal space. Same patient CT, look at the so-called extrapleural sign due to neurofibroma, the obtuse angles. One more patient comes with hypertension, POV of the chest, pheochromocytoma, a lateral mass, and which is in the posterior mediastinum. As I said earlier, most of the posterior mediastinal masses are neurogenic, and pheochromocytoma can also occur because of the sympathetic chain paralleling the vertebral column. Neurofibroma vagus nerve, very rare. This particular from the Montefiore Museum I got it. And then genitourinary tract, IVP, urethral notching due to multiple neurofibromata, and one on your right side, deformity of the bladder, elevation of the bladder, all due to the plexiform type of neurofibroma at the vesicoprostatic and vesico, and in females, vaginal neuroplasia. Again, IVP films, one on your left, pear-shaped bladder, and one on your right side. Entire bladder is displaced to the right side due to plexiform neurofibromatosis. Reference Radiographics 2004, volume 24. Esophagus, like GU tract, GI tract also may be involved. Look at this. Multiple corpus type of lesions, dilatations, stenosis. The Ehlers-Danlos syndrome also you may get similar finding. And then one on your right side, the lateral view of the pelvis, the barium enema. Look at the narrowed rectum due to extensive pressure, circumferential pressure by what? Neurofibromatosis. CT of the pelvis to show dumbbell type of neurofibroma. This is a sarcoma. Actually, you can't tell whether it is a fibroma or sarcoma. Radiologically, of course, if it is big, 5 centimeters or more, then you predict maybe neurofibrosarcoma. Malignant transformation in neurofibroma, single neurofibroma, is 29%. Malignant peripheral nerve sheath tumors, incidence is 4 to 5%. Other malignant tumors that may accompany neurofibromatosis in F1 are carcinoids. Pheochromocytoma, already we have mentioned, malignant pheochromocytoma. Embryonal tumors of the kidney, namely Wilms, neuroblastoma, rhabdomyosarcoma, and of course miscellaneous. Refer to Levy, Angela, et al., Radiographics 2005. Now, long talk about neurofibromatosis. One, because as I said earlier, 90% of the neurofibromas that we see belong to NF1. Now, the specific subspecialty of neurofibromatosis, namely neurofibromatosis 2. NF2 was first described in 1882 by Wishart. The disease was not separated from the usual von Reckling-Cosson's disease, we used to say neurofibromatosis, until 1987. Mutations in are rarely deletions in NF2 gene located on the long arm of chromosome 22. The disease is autosomal dominant, again with a high degree of penetration. Many patients have a strong family history. This is inherited autosomal dominant syndrome, as I mentioned already, characterized by multiple schwannomas, meningiomas, and ependymomas. Remember, I didn't say neurofibromatosis. The most common tumor associated with the syndrome is the vestibulocochlear, namely 8th nerve schwannoma. Please remember, vestibulocochlear schwannoma. And as many as 10% of patients with this tumor have NF2. You see, schwannoma of the 8th nerve, almost 10% of them may have NF2. It's also termed as schwannomatosis. or MISME syndrome. The acronym MISME is multiple inherited schwannomas, meningiomas, and ependymomas. Incidence approximately 1 in 50,000, much less than common enough. Some of the literature quotes 1 in 1 lakh, 2 lakhs also. The National Institute of Health Conference statement in 1988, they said the following: bilateral cranial nerve eighth masses seen with appropriate imaging techniques, a first degree relative with NF2, and a unilateral eighth nerve tumor mass are any or two of the following, namely neurofibroma, associated meningioma, glioma, schwannoma, juvenile posterior subcapsular lenticular opacity. Revised diagnostic criteria NF2 was proposed that adds a section for a presumptive or probable diagnosis of NF2. Definitive diagnosis of NF2 was mentioned in 1997 by Gutman et al. Bilateral eighth cranial nerve schwannomas on MRI or CT scan. No biopsy is necessary. Look at that. It is so specific. First degree relative with NF2 and either unilateral early onset eighth nerve schwannoma, age less than 30, or any of the two following again: meningioma, glioma, schwannoma, juvenile posterior subscapular lenticular opacity, otherwise called juvenile cortical cataract. Presumptive diagnosis of NF2, early onset of unilateral eighth cranial nerve schwannomas on MRI or CT scan detected in patients younger than 30 years. And any one of these following, namely again meningioma, glioma, schwannoma, and juvenile posterior subcapsular lenticular opacity. And multiple meningiomas, more than 2, and unilateral CN cranial nerve 8 schwannoma or one of the following. Again, same thing as glioma, schwannoma, etc. This is a 20-year-old male presented in NIMS, operated case of right optic nerve sheath meningioma 5 years ago, presented now with right proptosis and reduced vision and hearing also. This is, as you see, the Towns view, the widened acoustic canals, bilateral acoustic schwannomas. Can't say schwannomas, but already we have got proof. Operated on right side, you see the post-operative cranial defect on the right side. And then this is another case, nothing to do with that. Hyperostosis of parietal bone due to underlying meningioma. This is NF2. Isolated meningiomas can also occur, but if meningioma is associated with NF2, this schwannomas, then you categorize it under NF2. Look at the hyperostosis, a sunrise peculiar type of pattern, localized. Another case, CT showing enlarged internal artery canals, recurrence of optic nerve sheath meningioma, same patient, recurrence. Same patient's MRI, bilateral acoustic schwannomas with bright signals. Look at the arrows. Same patient again. That's why in NF2 we have to survey the entire spinal cord, because spinal cord tumors are very common, namely meningiomas, neurofibromatosis, etc., gliomas, etc. Same patient with meningioma in the cervicomedullary canal. Arrow points out in NF2. NF2 plain film. On your left side shows the acoustic canal widening. Conventional tomogram taken earlier. At that time we don't know it was NF2, but now we can categorize it retrospectively. Cutaneous manifestations much less in NF2, common than with NF1. Therefore, NF2 patients often are older when presenting. If the cutaneous manifestation is there, then a baby can be brought to the clinic. Few small pale cephalous spots, and then minimal absent cutaneous neurofibromas and no Lisch nodules. Again, neurofibromatosis type 2, gross specimen from a patient with type 2 neurofibromatosis, borrowed from Armed Forces Institute of Pathology, Washington. Look at the multiple convexity falx meningiomas, called meningioma factory, also not bilateral acoustic neuromas. Schwannoma on the right side, you could see the CT, right side of the picture, one on your left side, MRI, bright signal. Association of one more than one lesion in the spinal canal indicates NF2. Classical example. Again, on your left side, you see the MRI, both cutaneous, neurofibroma, and meningioma in the spinal canal. And then cross-section MRI, same patient. CNS manifestations of NF2, vestibulocochlear schwannomas, schwannomas of other cranial nerves can also occur, 3rd to 12th. Solitary or multiple meningiomas, either spinal or intracranial. References, Petronas, etc. Other tumors, questionable, where patients with NF2 develop intracranial gliomas at all. Astrocytomas of cord, ependymomas of the cord, most common intrinsic cord neoplasm. Multiple paraspinal schwannomas, often large, bilateral, and at multiple levels. It is important to survey the entire spinal canal, as I said already, in NF2, as there is greater incidence of tumors in the spinal canal in NF2, predominantly in extramedullary tumors. Conclusion, neurofibromatosis is a non-controversial. Today it's non-controversial, non-confusing, because it's categorized specifically majorly into NF1 and NF2, although NF3, NF4, NF5, NF8 are also described. It is a genetic disorder, no question about it, with a wide spectrum of imaging findings. What are the important points that you can take home? Take-home messages. Clinical diagnosis of NF1 is simple because of the cutaneous and various manifestations. Every organ in the body may be involved in NF1. That's why it is important to survey the entire body for neurofibromatosis. Isolated neurofibromatosis can occur without neurofibromatosis or NF1, anywhere without NF1. Different types of neurofibromatosis can exist. Genetic disorder, again to emphasize, hence many associated congenital anomalies may exist, like cardiac, NF2 expresses at a later stage. Imaging of spinal cord should be included in NF2. These are the important take-home messages.